We're going to talk about inflammation and we'll consider this topic over the course of the next couple of classes. We'll discuss causes of inflammation and mechanisms of development of acute inflammation and mediators of inflammation as well. Inflammation is a response of vascularized tissues to infection and tissue damage that brings cells and molecules of host defense from the circulation to the sites where they are needed to eliminate their offending agents. Although in common medical and everyday practice, inflammation suggests a harmful reaction, it is actually a protective response that is essential for survival. It serves to rid the hosts of both the initial cause of cell injury that could be caused by microbes or toxins and the consequences of such injury, the development of necrotic cells and tissues. The mediators of defense include phagocytic leukocytes, antibodies, and complement proteins. Most of these normally circulate in the blood, where they're sequestered so they cannot damage normal tissues, but can be rapidly recruited to any site in the body. Some of the cells involved in the inflammatory responses also reside in tissues, where they function as sentinels on the lookout for threats. The process of inflammation delivers leukocytes and proteins to foreign invaders, such as microbes, and to damaged or necrotic tissues, and it activates the recruited cells and molecules, which then function to eliminate the harmful or unwanted substances. Without inflammation, infections would go unchecked, wounds would never heal, and injured tissues would remain permanent festering sores. The typical inflammatory reaction develops through a series of sequential steps. The offending agent, which is located in extravascular tissues, is recognized by host cells and molecules. Leukocytes and plasma proteins are recruited from the circulation to the site where the offending agent is located. The leukocytes and proteins are activated and work together to destroy and eliminate the offending substance. The reaction is controlled and terminated, and the damaged tissue is repaired. Inflammation may be of two types: acute inflammation and chronic inflammation. We are going to consider the features of acute and chronic inflammation. But before that, let's understand what the term implies. Rapid response to infections and tissue damage is called acute inflammation. It typically develops within minutes or hours and is of short duration, lasting for several hours or a few days. Its main characteristics are the exudation of fluid and plasma proteins and the immigration of leukocytes, predominantly neutrophils, also known as polymorphonuclear leukocytes. When acute inflammation achieves its desired goal of eliminating the offenders, the reaction subsides and residual injury is repaired. But if the initial response fails to clear the stimulus, the reaction progresses to a protracted type of inflammation that is called chronic inflammation. Chronic inflammation may follow acute inflammation or arise de novo. It is of longer duration and is associated with more tissue destruction, the presence of lymphocytes and macrophages, the proliferation of blood vessels, and fibrosis. Inflammation is induced by chemical mediators that are produced by host cells in response to injurious stimuli. When a microbe enters a tissue or the tissue is injured, the presence of the infection or damage is sensed by resident cells, including macrophages, dendritic cells, mast cells, and other cell types. These cells secrete molecules, including cytokines and other mediators, that induce and regulate the subsequent inflammatory response. Inflammatory mediators are also produced from plasma proteins that react to the microbes or to products of necrotic cells. Some of these mediators promote the efflux of plasma and the recruitment of circulating leukocytes to the site where the offending agent is located. Mediators also activate the recruited leukocytes, enhancing the ability to destroy and remove the offending agent. Understanding the role of chemical mediators is important because most anti-inflammatory drugs target specific mediators. The external manifestation of inflammation, often called cardinal signs of inflammation, are heat, calor in Latin, redness, rubor, swelling, tumor, pain, dolor, and loss of function, funcția lesa. The first four of these were described more than 2,000 years ago by a Roman encyclopedist named Celsus, who wrote the then famous text De Medicina, and the fifth was added in the late 19th century by Rudolf Virchow, known as the father of modern pathology. These manifestations occur as consequences of the vascular changes and leukocyte recruitment and activation. In some situations, the inflammatory reaction becomes the cause of disease, and the damage it produces is its dominant feature. For example, inflammatory reactions to infections are often accompanied by local tissue damage and its associated signs and symptoms, including pain and functional impairment. Typically, however, these harmful consequences are self-limited and resolve as inflammation abates, leaving little or no permanent damage. In contrast, there are many diseases in which the inflammatory reaction is misdirected when it gets directed against self-tissues in autoimmune diseases, or it occurs against normally harmless environmental substances that evoke an immune response, as an example of allergies, or is excessively prolonged, as in cases of infections by microbes that resist eradication. Inflammatory reactions underlie common chronic diseases such as rheumatoid arthritis, atherosclerosis, and lung fibrosis, as well as life-threatening hypersensitivity reactions to insect bites, drugs, and toxins. For this reason, our pharmacies abound with anti-inflammatory drugs, which ideally would control the harmful sequence of inflammation, yet not interfere with its beneficial effects. In fact, inflammation may contribute to a variety of diseases that are thought to be primarily metabolic, degenerative, or genetic disorders such as type 2 diabetes, Alzheimer's disease, and cancer. Hence, anti-inflammatory drugs may well have a broader role than currently indicated. In recognition of the wide-ranging harmful consequences of inflammation, the lay press has rather melodramatically referred to it as the silent killer. Not only excessive inflammation, but also defective inflammation is responsible for serious illness. Too little inflammation, which is typically manifested by increased susceptibility to infections, is most often caused by a reduced number of leukocytes resulting from replacement of the bone marrow by cancers and suppression of the marrow by therapies for cancer and graft rejection. Recall the leukocytes, the cells of the inflammatory response that arise from progenitors in the bone marrow. Hence, any compromise of marrow function will diminish the generation of mature leukocytes. Inherited genetic abnormalities of leukocyte function are rare disorders, but they provide valuable information about the mechanism of leukocyte response. Inflammation is terminated when the offending agent is eliminated. The reaction resolves because mediators are broken down and dissipated, and leukocytes have a short lifespan in tissues. In addition, anti-inflammatory mechanisms are activated, serving to control the response and prevent it from causing excessive damage to the host. After inflammation has achieved its goal of eliminating the offending agents, it sets into motion the process of tissue repair. Repair consists of a series of events that heal damaged tissue. In the process, the injured tissue is replaced through regeneration of surviving cells and filling of residual defects with connective tissue. This process is known as scarring. Inflammatory reactions may be triggered by a variety of stimuli. Infections like bacterial, viral, fungal, parasitic infection, and microbial toxins are among the most common and medically important causes of inflammation. Different infectious pathogens elicit distinct inflammatory responses, from mild acute inflammation that causes little or no lasting damage and successfully eradicates the infection, to severe systemic reactions that can be fatal, to prolonged chronic reactions that cause extensive tissue injury. The morphologic pattern of the response can be useful in identifying its etiology. Tissue necrosis elicits inflammation regardless of the cause of cell death, which may include ischemia, implying reduced blood flow, the cause of myocardial infarction, or trauma and physical and chemical injury like thermal injury as it burns or frostbite, irradiation, exposure to some environmental chemicals. Several molecules released from necrotic cells are known to trigger inflammation. Foreign bodies is another cause of inflammation, like splinters, dirt, sutures, may elicit inflammation by themselves or because they cause traumatic tissue injury or carry microbes. Even some amounts are deposited in tissue. Even some endogenous substances stimulate potentially harmful inflammation if large amounts are deposited in tissues. Such substances include urate crystals in the diseased gout and cholesterol crystals in atherosclerosis. Immune reactions, also called hypersensitivity, are reactions in which the normally protective immune system damages the individual's own tissue. The injurious immune responses may be directed against self-antigens, causing autoimmune diseases, or may be inappropriate reactions against environmental substances, as in allergies, or against microbes. Inflammation is a major cause of tissue injury in these diseases. Because the stimuli for the inflammatory responses in autoimmune and allergic diseases cannot be eliminated, these reactions tend to be persistent and difficult to cure, and are often associated with chronic inflammation and are important causes of morbidity and mortality. The first step in inflammatory responses is the recognition of microbes and necrotic cells by cellular receptors and circulating proteins. The cells and receptors that recognize invaders evolved as adaptation of multicellular organisms to the presence of microbes in the environment, and the responses they trigger are critical for survival. Phagocytes, dendritic cells, the cells in epithelia and all tissues whose function is to capture microbes, and many other cells express receptors that detect the presence of infectious pathogens. The best defined of these receptors belong to the family of toll-like receptors, abbreviated as TLR, which are named for the founding member toll, a gene that was discovered in Drosophila. Toll-like receptors are located in plasma membranes and endosomes, so they are able to detect extracellular and ingested microbes. Other microbial sensors are present in the cytoplasm of cells. Toll-like receptors recognize motifs common to many microbes, often called as pathogen-associated molecular patterns, abbreviated as PAMPs. Recognition of microbes by these receptors stimulates the production and expression of a number of secreted and membrane proteins. These proteins include cytokines that induce inflammation, antiviral cytokines, interferons, and cytokines and membrane proteins that promote lymphocyte activation and even more potent immune responses. All cells have cytosolic receptors that recognize molecules that are liberated or altered as a consequence of cell damage, and are hence appropriately called damage-associated molecular patterns, abbreviated as DAMP. These Molecules include uric acid, a product of DNA breakdown, ATP, released from damaged mitochondria, reduced intracellular K concentrations, reflecting loss of ions because of plasma membrane injury, DNA, when it is released into the cytoplasm and not sequestered in nuclei as it should be normally, and many others. The receptors activate a multi-protein cytosolic complex called the inflammasome, which induces the production of the cytokine interleukin-1. Interleukin-1 recruits leukocytes and thus induces inflammation. Gain-of-function mutations in the cytosolic receptors are the cause of rare diseases known as anti-inflammatory syndromes that are characterized by spontaneous inflammation. Interleukin-1 antagonists are effective treatments for these disorders. The inflammasome also have been implicated in inflammatory reactions to urate crystals, the cause of gout, cholesterol crystals in atherosclerosis, lipids in metabolic syndrome and obesity-associated diabetes, and amyloid deposits in the brain in Alzheimer's disease. Several plasma proteins recognize microbes and function to destroy blood-borne microbes and to stimulate inflammation at tissue sites of infection. The complement system reacts against microbes and produces mediators of inflammation. A circulating protein called mannose-binding lectin recognizes microbial sugars and promotes ingestion of microbes and activation of the complement system. Other proteins called colectins also bind to microbes and promote their phagocytosis. There are several features and causes of inflammation that should be mentioned. Inflammation is a beneficial host response to foreign invaders and necrotic tissue, but also may cause tissue damage. The main components of inflammation are a vascular reaction and a cellular response. Both are activated by mediators that are derived from plasma proteins and various cells. The steps of the inflammatory response can be remembered as the 5 R's: recognition of the injurious agent, recruitment of leukocytes, removal of the agent, regulation of the response, and resolution or repair. The cause of inflammation include infections, tissue necrosis, foreign bodies, trauma, and immune responses. Epithelial cells, tissue macrophages, and dendritic cells, leukocytes, and other cell types express receptors that sense the presence of microbes and necrotic cells. Circulating proteins recognize microbes that have entered the blood. The outcome of acute inflammation is either elimination of the noxious stimulus, followed by decline of the reaction and repair of the damaged tissue, or persistent injury resulting in chronic inflammation. The vascular reactions of acute inflammation consist of changes in the flow of blood and the permeability of vessels, both designed to maximize the movement of plasma proteins and leukocytes out of the circulation and into the size of infection or injury. The escape of fluid, proteins, and blood cells from the vascular system into interstitial tissues or body cavities is known as exudation. An exudate is an extravascular fluid that has a high protein concentration and contains cellular debris. Its presence implies that there is an increase in the permeability of small blood vessels, typically during an inflammatory reaction. In contrast, a transudate is a fluid with a low protein content, little or no cellular material, and low specific gravity. It is essentially an ultrafiltrate of blood plasma that is produced as a result of osmotic or hydrostatic imbalance across vessels with normal vascular permeability. Edema denotes an excess of fluid in the interstitial tissue or serous cavities. It can be either an exudate or transudate. Pus or purulent exudate is an inflammatory exudate rich in leukocytes, mostly neutrophils, the debris of dead cells, and in many cases microbes. Changes in vascular flow and caliber begin early after injury and consist of the following. Vasodilation is induced by the action of several mediators, notably histamine, on vascular smooth muscle. It is one of the earliest manifestations of acute inflammation and may be preceded by transient vasoconstriction. Vasodilation first involves the arterioles and then leads to the opening of new capillary beds in the area. The result is increased blood flow, which is the cause of heat and redness, erythema at the site of inflammation. Vasodilation is quickly followed by increased permeability of the microvasculature with the outpouring of protein-rich fluid, an exudate, into the extravascular tissues. The loss of fluid and increased vessel diameter lead to slower blood flow, concentration of red cells in small vessels, and increased viscosity of the blood. These changes result in stasis of blood flow, engorgement of small vessels jammed with slowly moving red cells, seen histologically as vascular congestion and externally as localized redness erythema of the involved tissue. As stasis develops, blood leukocytes, principally neutrophils, accumulate along the vascular endothelium. You can see it on the picture signified by the arrows. At the same time, endothelial cells are activated by mediators produced at sites of infection and tissue damage and express increased levels of adhesion molecules. Leukocytes then adhere to the endothelium, and soon afterward they migrate through the vascular wall into the interstitial tissue. There are several mechanisms responsible for increased vascular permeability in acute inflammation, which include retraction of endothelial cells, endothelial injury, and increased transport of fluids and proteins known as transcytosis. Retraction of endothelial cells resulting in opening of interendothelial spaces is the most common mechanism of vascular leakage. It is elicited by histamine, bradykinin, leukotrienes, and other chemical mediators. It occurs rapidly after exposure to the mediator within 15 to 30 minutes after start and is usually short-lived. Hence, it is referred to as the immediate transient response. The main signs for this rapid increase in vascular permeability are post-capillary venous. Endothelial injury resulting in endothelial cell necrosis and detachment. Direct damage to the endothelium is encountered in severe injuries, for example in burns, or is induced by the actions of microbes and microbial toxins that target endothelial cells. Neutrophils that adhere to the endothelium during inflammation may also injure the endothelial cells and thus amplify the reaction. In most instances, leakage starts immediately after injury and is sustained for several hours until the damaged vessels are thrombosed or repaired. Increased transport of fluids and proteins is known as transcytosis, and it happens through the endothelial cell. This process, documented in experimental models, may involve intracellular channels that open in response to certain factors, such as vascular endothelial growth factor that promote vascular leakage. Its contribution to the vascular permeability seen in acute inflammation in humans is unclear. Although these mechanisms of increased vascular permeability were described separately, all probably contribute in varying degrees in responses to most stimuli. For example, at different stages of the thermal burn, leakage results from endothelial retraction caused by inflammatory mediators and direct and leukocyte-dependent endothelial injury. In addition to blood vessels, lymphatic vessels also participate in acute inflammation. The system of lymphatics and lymph nodes filters and polices the extravascular fluids. Lymphatics drain the small amount of extravascular fluid that seeps out of capillaries under normal circumstances. In inflammation, lymph flow is increased to help drain edema fluid that accumulates because of increased vascular permeability. In addition to fluid, leukocytes and cell debris, as well as microbes, may find their way into lymph. Lymphatic vessels, like blood vessels, proliferate during inflammatory reactions to handle the increased load. The lymphatics may become secondarily inflamed. This process is known as lymphangitis, as may the draining lymph nodes or lymphadenitis. On the picture you see acute lymphadenitis. Inflamed lymph nodes are often enlarged because of increased cellularity. This constellation of pathologic changes is termed reactive or inflammatory lymphadenitis. For clinicians, the presence of red streaks near a skin wound is a telltale sign of an infection in the wound. This streaking follows the course of the lymphatic channels and indicates the presence of lymphangitis. It may be accompanied by painful enlargement of the draining lymph nodes, indicating lymphadenitis. Leukocytes that are recruited to sites of inflammation perform the key function of eliminating the offending agents. The most important leukocytes in typical inflammatory reactions are the ones capable of phagocytosis, namely neutrophils and macrophages. The journey of leukocytes from the vessel lumen to the tissue is a multi-step process that is mediated and controlled by adhesion molecules and cytokines. Leukocytes normally flow rapidly in the blood, and in inflammation they have to be stopped and then brought to the offending agent of the site of tissue damage outside the vessels. This process can be divided into phases, consisting first of adhesion of leukocyte to endothelium at the site of inflammation, then transmigration of leukocyte through the vessel wall, and movement of the cells toward the offending agent. Different molecules play important roles in each of these steps. Neutrophils are produced in the bone marrow and rapidly recruited to sites of inflammation. Macrophages are slower responders. Leukocytes ingest and destroy bacteria and other microbes, as well as necrotic tissue and foreign substances. Macrophages also produce growth factors that aid in repair. A price that is paid for the defensive potency of leukocytes is that when strongly activated, they may induce tissue damage and prolong inflammation, because the leukocyte products that destroyed microbes and help clean up necrotic tissue can also produce collateral damage of normal host tissues. When there is systemic activation of inflammation, as may occur when there is invasion of the bloodstream by bacteria, the resulting systemic inflammatory response may even be lethal. When blood flows from capillaries into postcapillary venules, circulating cells are swept by laminar flow against the vessel wall. Red cells, being smaller, tend to move faster than the larger white cells. As a result, red cells are confined to the central axial column, and leukocytes are pushed out toward the wall of the vessel, but the flow prevents the cells from attaching to the endothelium. As the blood flow slows early in inflammation, the process that is known as stasis, hemodynamic conditions change. Wall shear stress decreases and more white cells assume a peripheral position along the endothelial surface. This is shown by the arrows, yellow arrows on the left picture. This process of leukocyte redistribution is called margination. By moving close to the vessel wall, leukocytes are able to detect and react to changes in the endothelium. If the endothelial cells are activated by cytokines and other mediators produced locally, they express adhesion molecules to which the leukocytes attach loosely. These cells bind and detach and thus begin to tumble on the endothelial surface, a process called rolling. The cells finally come to rest at some point, where they adhere firmly, resembling pebbles over which a stream runs without disturbing them. The attachment of leukocytes to endothelial cells is mediated by complementary adhesion molecules on the two cell types whose expression is enhanced by cytokines. Cytokines are secreted by cells in tissues in response to microbes and other injurious agents, thus ensuring that leukocytes are recruited to the tissues where these stimuli are present. The two major families of molecules involved in leukocyte adhesion and migration are the selectins and integrins. These molecules are expressed on leukocytes and endothelial cells as are via ligands. Selectins mediate the initial weak interaction between leukocytes and endothelium. Selectins are receptors expressed on leukocytes and endothelium that contain an extracellular domain that binds sugars, hence the lectin part of the name. The three members of the family are E-selectin, also called CD6-2E, that is expressed on endothelial cells, P-selectin, or CD6-2P, present on platelets and endothelium, and L-selectin, CD6-2L, found on the surface of most leukocytes. The ligands for selectins are sialic acid-containing oligosaccharides bound to glycoprotein backbones. The endothelial selectins are typically expressed at low levels or not at all on unactivated endothelium and are upregulated after stimulation by cytokines and other mediators. Therefore, binding of leukocytes is largely restricted to the endothelium at sites of infection or tissue injury where the mediators are produced. For example, in unactivated endothelial cells, P-selectin is found primarily in intracellular viable pallid bodies. However, within minutes of exposure to mediators such as histamine or thrombin, P-selectin is distributed to the cell surface. Similarly, E-selectin and the ligand for the L-selectin are expressed on endothelium only after stimulation by interleukin-1 and tumor necrosis factor, abbreviated as TNF. Cytokines that are produced by tissue macrophages, dendritic cells, mast cells, and endothelial cells themselves, following encounters with microbes and dead tissues. Leukocytes express L-selectin at the tips of their microvilli and also express ligands for E and P-selectins, all of which bind to the complementary molecules on the endothelial cells. These are low affinity interactions with a fast off rate, and they are easily disrupted by the flowing blood. As a result, the bound leukocytes bind, detach, and bind again, and thus begin to roll along the endothelial surface. These weak selectin-mediated rolling interactions slow down the leukocytes and give them the opportunity to recognize additional adhesion molecules on the endothelium. Firm adhesion of leukocytes to endothelium is mediated by a family of leukocyte surface proteins called integrins. Integrins are transmembrane two-chain glycoproteins that mediate the adhesion of leukocytes to endothelium and of various cells to their extracellular matrix. They are normally expressed on leukocyte plasma membranes in a low affinity form and do not adhere to the specific ligands until the leukocytes are activated by chemokines. Chemokines are chemoattractant cytokines that are secreted by many cells at sites of inflammation, bind to endothelial cells' proteoglycans, and are displayed at high concentration on the endothelial surface. When the rolling leukocytes encounter the displayed chemokines, the cells are activated and their integrins undergo conformational changes and cluster together, thus converting to a high affinity form. At the same time, other cytokines, notably tumor necrosis factor and interleukin-1, activate endothelial cells to increase the expression of ligands for integrins. These ligands include intercellular adhesion molecule 1, ICAM1, which binds to the integrin's leukocyte function-associated antigen 1, LFA1, also called CD11A, CD18. The other ligand is a macrophage 1 antigen, or MAC1, or CD11, BCD18. There is also vascular cell adhesion molecule 1, VCAM, which binds to the integrin very late antigen 4. The combination of cytokine-induced expression of integrin ligands on the endothelium and increased affinity of integrins on the leukocytes results in firm integrin-mediated binding of the leukocytes to the endothelium at the site of inflammation. The leukocytes stop rolling, and engagement of integrins by their ligands delivers signals, leading to cytoskeletal changes that arrest the leukocytes and firmly attach them to the endothelium. The most telling proof of the importance of leukocyte adhesion molecules is the existence of genetic deficiencies in these molecules that result in recurrent bacterial infections as a consequence of impaired leukocyte adhesion and defective inflammation. After being arrested on the endothelial surface, leukocytes migrate through the vessel wall primarily by squeezing between cells at intracellular junctions. This is shown by the arrows on the right picture. This extravasation of leukocytes, called transmigration, occurs mainly in postcapillary venules, the site at which there is maximal retraction of endothelial cells. Further movement of leukocytes is driven by chemokines produced in extravascular tissues, which stimulate leukocytes to travel along a chemical gradient. In addition, platelet endothelial cell adhesion molecule 1, PCAM1, also called CD31, an adhesion molecule of immunoglobulin, superfamily expressed on leukocytes and endothelial cells, mediates the binding events needed for leukocytes to traverse the endothelium. After traversing the endothelium, leukocytes pierce the basement membrane, probably by secreting collagenases, and they enter the extravascular tissue. Typically, the vessel wall is not injured during leukocyte transmigration. After exiting the circulation, leukocytes move to the tissues toward the site of injury by a process called chemotaxis, which is defined as locomotion along a chemical gradient. Both exogenous and endogenous substances can act as chemoattractants, including the following: bacterial products, particularly peptides with N,4-methionine termini, cytokines, especially those of the chemokine family, components of the complement system, particularly C5a, products of lipoxygenase pathway of arachidonic acid metabolism, particularly leukotriene B4. These chemoattractants are produced by microbes and by host cells in response to infections and tissue damage and during immunologic reactions. All act by binding to 7 transmembrane G protein coupled receptors on the surface of leukocytes. Signals initiated from these receptors activate second messengers that induce polymerization of actin, resulting in increased amounts at the leading edge of the cell and localization of myosin filaments at the back. The leukocyte moves by extending filopodia that pull the back of the cell in the direction of extension, much like the front wheels pull an automobile with front-wheel drive. The net result is the leukocyte migrate toward the inflammatory stimulus in the direction of the locally produced chemoattractants. The nature of the leukocyte infiltrate varies with the age of the inflammatory response and the type of stimulus. In most forms of acute inflammation, neutrophils predominate in the inflammatory infiltrate during the first 6 to 24 hours and are gradually replaced by monocyte-derived macrophages over 24 to 48 hours. On the picture you see early inflammatory reaction that includes neutrophilic infiltrates, shown by the yellow arrows, in the myocardium after ischemic necrosis or infarction. There are several reasons for the early preponderance of neutrophils. They are more numerous in the blood than other leukocytes. They respond more rapidly to chemokines, and they may attach more firmly to the adhesion molecules that are rapidly induced on endothelial cells such as P and E selectins. After entering tissues, neutrophils are short-lived. They undergo apoptosis and disappear within 24 to 48 hours. Macrophages not only survive longer, but also may proliferate in the tissues, and thus they become the dominant population in prolonged inflammatory reactions. On the picture you see late mononuclear cellular infiltrates in the myocardium after ischemic necrosis. There are, however, exceptions to this stereotypic pattern of cellular infiltration in certain infections. For example, those produced by Pseudomonas bacteria, the cellular infiltrate is dominated by neutrophils for several days. In viral infections, lymphocytes may be the first cells to arrive. Some hypersensitivity reactions are dominated by activated lymphocytes, macrophages, and plasma cells, reflecting the immune response. And in allergic reactions, eosinophils may be prominent cell type. The molecular understanding of a leukocyte recruitment and migration has provided a large number of potential therapeutic targets for controlling harmful inflammation. Agents that block tumor necrosis factor, one of the major cytokines in leukocytes recruitment, are among the most successful therapeutics ever developed for chronic inflammatory diseases, and antagonists of leukocytes integrins are approved for inflammatory diseases and are being tested in clinical trials. Predictably, these antagonists not only have the desired effect of controlling the inflammation, but can also compromise the ability of treated patients to defend themselves against microbes, which of course is the physiologic function of the inflammatory response. Leukocytes are recruited from the blood into the extravascular tissue where infectious pathogens or damaged tissues may be located. They migrate to the site of infection or tissue injury, and they are activated to perform the function. Leukocyte recruitment is a multi-step process consisting of loose attachment to and rolling on endothelium mediated by selectins, firm attachment to endothelium mediated by integrins, and migration through interendothelial gaps. Various cytokines promote the expression of selectins and integrin ligands on the endothelium, including TNF and interleukin-1, increase the avidity of integrins for their ligands, chemokines, and promote directional migration of leukocytes, also chemokines. Tissue macrophages and other cells responding to the pathogens of damaged tissue produce many of these cytokines. Neutrophils predominate in the early inflammatory infiltrate and are later replaced by monocytes and macrophages. Recognition of microbes or dead cells induces several responses in leukocytes that are collectively called leukocyte activation. After leukocytes, particularly neutrophils and monocytes, have been recruited to a site of infection or tissue injury, they must be activated to perform their functions. This makes perfect sense because while we want our defendants to patrol our body constantly, it would be wasteful to keep them at a high level of alert and expending energy before they are required. The functional responses that are most important for destruction of microbes and other offenders are phagocytosis and intracellular killing. Several other responses aid in the defensive function of inflammation and may contribute to its injurious consequences. Phagocytosis involves 3 sequential steps: recognition and attachment of the particle to be ingested by the leukocyte, engulfment with subsequent formation of the phagocytic vacuole, and the killing or degradation of the ingested material, shown in the picture. These steps are triggered by activation of phagocytes by microbes, necrotic debris, and various mediators. Mannose receptors, scavenger receptors, and receptors for various opsonins bind and ingest microbes. The macrophage mannose receptor is a lectin that binds terminal mannose and fucose residues of glycoproteins and glycolipids. These sugars are typically part of molecules found on microbial cell walls, whereas mammalian glycoproteins and glycolipids contain terminal sialic acid or N-acetylgalactosamine. Therefore, the mannose receptor recognizes microbes and not host cells. Scavenger receptors bind and ingest low-density lipoprotein particles as well as a variety of microbes. The efficiency of phagocytosis is greatly enhanced when microbes are opsonized, coated by specific proteins, opsonins, for which the phagocytes express high affinity receptors. The major opsonins are immunoglobulin G antibodies, the C3b breakdown product of complement activation, and certain plasma lectins, notably mannose-binding lectin, all of which are recognized by specific receptors on leukocytes. After a particle is bound to phagocyte receptors, extension of the cytoplasm flow around it, and the plasma membrane pinches off to form a cytosolic vesicle, phagosome, that encloses the particle. The phagosome then fuses with lysosomes, resulting in the discharge of lysosomal contents into the phagolysosome. During the process, the phagocyte also may release some granule contents into the extracellular space, thereby damaging innocent bystander normal cells. The killing of microbes and the destruction of ingested materials are accomplished by reactive oxygen species, also called reactive oxygen intermediates, reactive nitrogen species, mainly derived from nitric oxide, and lysosomal enzymes. This is the final step in the elimination of infectious agents and necrotic cells. The killing and degradation of microbes and elimination of dead cell debris within neutrophils and macrophages occur most efficiently after their activation. All these killing mechanisms are normally sequestered in lysosomes, to which phagocytized materials are brought. Those potentially harmful substances are segregated from the cell's cytoplasm and nucleus to avoid damage to the phagocyte while it is performing its normal function. Reactive oxygen species are produced by the rapid assembly and activation of multi-component enzyme, phagocyte oxidase, also called NADPH oxidase, which oxidizes reduced nicotinamide adenine dinucleotide phosphate, and in the process reduces oxygen to the superoxide anion. In neutrophils, this oxidative reaction is tightly linked to phagocytosis and is called the respiratory burst. Genetic defects in the generation of reactive oxygen species are the cause of immunodeficiency diseases called chronic granulomatous disease. Nitric oxide, a soluble gas produced from arginine by the action of nitric oxide synthase, also participates in microbial killing. There are 3 different types of nitric oxide: endothelial, abbreviated as ENOS, neuronal as NNOS, and inducible as INOS. Endothelial nitric oxide and neuronal nitric oxide are constitutively expressed at low levels, and the nitric oxide they generate acts to maintain vascular tone and as a neurotransmitter. Inducible nitric oxide is involved in microbial killing and expressed when macrophages are activated by cytokines. These nitrogen-derived radicals, similar to reactive oxygen species, attack and damage the lipids, proteins, and nucleic acids on microbes and host cells. Neutrophils and monocytes contain granules packed with enzymes and antimicrobial proteins that degrade microbes and dead tissues and may contribute to tissue damage. These granules are actively secretory and thus distinct from classical lysosomes. Neutrophils have two main types of granules. The smaller specific or secondary granules contain lysozyme, collagenase, gelatinase, lactoferrin, plasminogen activator, histaminase, and alkaline phosphatase. The larger azurophil or primary granules contain mieloperoxidase, bactericidal factors such as defensins, acid hydrolases, and a variety of neutral proteases, elactase, cathepsin G, nonspecific collagenases, proteinase-free. Phagocytic vesicles containing engulfed material may fuse with these granules and with lysosomes, and the ingested materials are destroyed. In addition, both types of granules also undergo exocytosis, degranulation, leading to the extracellular release of granule contents. Different granule enzymes serve different functions. Acid proteases degrade bacteria and debris within phagolysosomes, which are acidified by membrane-bound proton pumps. Neutral proteases are capable of degrading various extracellular components such as collagen, basement membrane, fibrin, elastin, and cartilage, resulting in the tissue destruction that accompanies inflammatory processes. Neutrophil elastase combats infections by degrading virulence factors of bacteria. Macrophages also contain acid hydrolases, collagenase, elastase, phospholipase, and plasminogen activator. Because of the destructive effects of granule enzymes, the initial leukocytic infiltration, if unchecked, can potentiate further inflammation by damaging tissues. These harmful proteases, however, are normally controlled by a system of antiproteases in the serum and tissue fluids. Foremost among these is alpha-1 antitrypsin, which is the major inhibitor of neutrophil elastase. A deficiency of these inhibitors may lead to sustained action of leukocyte proteases, and is the case in patients with alpha-1 antitrypsin deficiency. Neutrophil extracellular traps, nets, are extracellular fibrillar networks that concentrate antimicrobial substances at sites of infection and prevent the spread of the microbes by trapping them in the fibrils. They are produced by neutrophils in response to infectious pathogens, mainly bacteria and fungi, and inflammatory mediators, including chemokines, cytokines, and complement proteins. The extracellular traps consist of a vicious meshwork of nuclear chromatin that binds and concentrates granule proteins such as antimicrobial peptides and enzymes. Neutrophil extracellular traps provide an additional mechanism of killing microbes that does not involve phagocytosis. In the process of neutrophil extracellular traps formation, the nuclei of the neutrophils are lost, leading to the death of the cells, sometimes called mitosis, representing a distinctive form of cell death affecting neutrophils. Neutrophil extracellular traps also have been detected in the blood during sepsis. The nuclear chromatin in the neutrophil extracellular trap, which includes histones and associated DNA, may be a source of nuclear antigens in systemic autoimmune diseases, particularly lupus, in which individuals react against their own DNA and nucleoproteins. Leukocytes are important mediators of injury to normal cells and tissues under several circumstances. As part of a normal defense reaction against infectious microbes, when tissues at or near the site of infection suffer collateral damage. In some infections that are difficult to eradicate, such as tuberculosis and certain viral diseases such as hepatitis, the prolonged host response contributes more to the pathology than does the microbe itself. When the inflammatory response is inappropriately directed against host tissues, as in certain autoimmune diseases, when the host hyperreacts against usually harmless environmental substances, as in allergic diseases, including asthma and some drug reactions. Leukocytes damage tissues by releasing injurious molecules. The potentially toxic contents of granules are released by leukocytes into the extracellular milieu by several mechanisms. Controlled secretion of granule contents following degranulation is a normal response of activated leukocytes. If phagocytes encounter materials that cannot be easily ingested, such as immune complexes deposited on immovable flat surfaces, like glomerular basement membrane, the inability of the leukocyte to surround and ingest these substances, known as frustrated phagocytosis, triggers strong activation and also the release of large amounts of granule enzymes into the extracellular environment. Some phagocytosed substances, such as urate and silica crystals, may damage the membrane of the phagolysosome and also lead to the release of damaging contents. In addition to eliminating microbes and dead cells, activated leukocytes play several other roles in host defense. Importantly, these cells, especially macrophages, produce cytokines that can either amplify or limit inflammatory reactions, growth factors that stimulate the proliferation of endothelial cells and fibroblasts and the synthesis of collagen, and enzymes that remodel connective tissues. Because of these activities, macrophages also have central roles in orchestrating chronic inflammation and tissue repair after the inflammation has subsided. However, it has become clear that some T lymphocytes, which are cells of adaptive immunity, also contribute to acute inflammation. The most important of the cells are those that produce the cytokine interleukin 17, so-called Th17 cells. Interleukin 17 induces the secretion of chemokines that recruit other leukocytes. In the absence of effective responses, interleukin 17 individuals are susceptible to fungal and bacterial infections, and the skin abscesses that develop are called abscesses, like in the classic features of acute inflammation, such as warmth and redness. We're going to look at the determination of the acute inflammatory response on this slide. Such a powerful system of host defense, with its inherent capacity to cause tissue injury, needs tight controls to minimize damage. In part, inflammation declines after the offending agents are removed simply because the mediators of inflammation are produced in rapid bursts. Only as long as the stimulus persists, have short half-lives, and are degraded after their release. Neutrophils also have short half-lives in tissues and die by apoptosis within hours to a day or two after leaving the blood. As inflammation develops, the process itself triggers a variety of stop signals that actively terminate the reaction. These active termination mechanisms include a switch in the type of arachidonic acid metabolite produced from pro-inflammatory leukotrienes to anti-inflammatory lipoxins, and the liberation of anti-inflammatory cytokines, including transforming growth factor beta, TGF-beta, and interleukin-10 from macrophages and other cells. Other control mechanisms that have been demonstrated experimentally include neutral impulses, which inhibit the production of TNF in macrophages. The mediators of inflammation are the substances that initiate and regulate inflammatory reactions. The most important mediators of acute inflammation are vasoactive amines, lipid products, prostaglandins and leukotrienes, cytokines including chemokines, and products of complement activation. Let's begin by summarizing the general properties of the mediators of inflammation and then discuss some of the more important molecules. Mediators may be produced locally by cells at the site of inflammation or may be derived from circulating inactive precursors that are activated at the site of inflammation. Cell-derived mediators are rapidly released from intracellular granules or are synthesized de novo, like prostaglandins, leukotrienes, and cytokines, in response to a stimulus. The major cell types that produce mediators or acute inflammation are tissue macrophages, dendritic cells, and mast cells, but platelets, neutrophils, and endothelial cells, and most epithelia also can be induced to elaborate some of the mediators. Therefore, cell-derived mediators are most important for reactions against offending agents in tissues. Plasma-derived mediators, like complement proteins, are present in the circulation as inactive precursors that might be activated usually by a series of proteolytic cleavages to acquire their biologic properties. They are produced mainly in liver and are effective against circulating microbes and also can be reduced into tissues. The two major vasoactive amines, so named because they have important actions on blood vessels, are histamine and serotonin. They are stored as preformed molecules in cells and are therefore among the first mediators to be released during inflammation. The richest sources of histamine are mast cells, which are normally present in the connective tissue adjacent to blood vessels. Histamine also is found in blood basophils and platelets. It is stored in mast cell granules and is released by degranulation in response to a variety of stimuli, including physical injury, such as trauma, cold, or heat by unknown mechanisms. Binding of antibody to mast cells, which underlies immediate hypersensitivity allergic reactions. Products of complement called anaphylatoxins. Antibodies and complement products bind to specific receptors on mast cells and trigger signaling pathways that induce rapid degranulation. Neuropeptides like substance P and cytokines like interleukin 1 and interleukin 8 also might trigger release of histamine. Histamine causes dilation of arterioles and increases the permeability of venules. Histamine is considered the principal mediator of the immediate transit phase of increased vascular permeability, producing endothelial gaps in post-capillary venules. Its vasoactive effects are mediated mainly via binding to receptors called H1 receptors on microvascular endothelial cells. The antihistamine drugs that are commonly used to treat some inflammatory reactions, such as allergies, are H1 receptor antagonists that bind to and block the receptor. Histamine also causes contraction of some smooth muscles. Serotonin is a preformed vasoactive mediator present in platelets and certain neuroendocrine cells, such as in the gastrointestinal tract and in mast cells in rodents but not humans. Its primary function is as neurotransmitter in the gastrointestinal tract. It also is a vasoconstrictor, but the importance of the action in inflammation is unclear. The lipid mediators prostaglandins and leukotrienes are produced from arachidonic acid present in membrane phospholipids, and they stimulate vascular and cellular reactions in acute inflammation. Arachidonic acid is a 20-carbon polyunsaturated fatty acid that is derived from dietary sources or by conversion from the essential fatty acid linoleic acid. Most cellular arachidonic acid is esterified and incorporated into membrane phospholipids. Mechanical, chemical, and physical stimuli or other mediators trigger the release of arachidonic acid from membranes by activating cellular phospholipases, mainly phospholipase A2. Once freed from the membrane, arachidonic acid is rapidly converted to bioactive mediators. These mediators, also called eicosanoids, because they are derived from 20-carbon fatty acids and Greek korza is 20, are synthesized by two major classes of enzymes. Cyclooxygenases, which generate prostaglandins, and lipoxygenases, which produce leukotrienes and lipoxins. Eicosanoids bind to G protein-coupled receptors on many cell types and can mediate virtually every step of inflammation. Prostaglandins are produced by mast cells, macrophages, endothelial cells, and many other cell types, and are involved in the vascular and systemic reactions of inflammation. The most important prostaglandin in inflammation are prostaglandin 2, PGD2, PGF2A, PGI2 prostacyclin, and thromboxane A2, each of which is derived by the action of a specific enzyme on an intermediate in the pathway. PGD2 is the major prostaglandin made by mast cells. It causes vasodilation and increases the permeability of postcapillary venules, thus potentiating exudation and resultant edema. PGD2 also is a chemoattractant for neutrophils. Platelets contain the enzyme thromboxane synthase, which is responsible for synthesizing thromboxane A2, the major platelet eicosanoid. Thromboxane A2 is a potent platelet aggregating agent and vasoconstrictor and thus promotes thrombosis. Vascular endothelium contains prostacyclin synthase, which is responsible for the formation of prostacyclin PGI2 and its stable end product PGF1A. Prostacyclin is a vasodilator and a potent inhibitor of platelet aggregation, and thus serves to prevent thrombus formation on normal endothelial cells. Prostaglandins are involved in the pathogenesis of pain and fever, two common systemic manifestations of inflammation. Leukotrienes are produced in leukocytes and mast cells by the action of lipoxygenase and are involved in vascular and smooth muscle reactions and leukocyte recruitment. The synthesis of leukotrienes involves multiple steps, the first of which generates leukotriene A4. LTB4 is produced by neutrophils and some macrophages and is a potent chemotactic agent and activator of neutrophils, causing aggregation and adhesion of the cells to venular endothelium, generation of species, and release of lysosomal enzymes. We are going to finish with this slide today, and we'll continue discussion of the acute inflammation during the next lecture.